Okay, thank you so much. I'd like to thank the organizers of the APCIS and also my colleagues at Sejong for inviting me back again this year. So a lot of these slides you've seen and you've heard various bits and pieces of this, but hopefully this talk will sort of bring everything together that we've been talking about this afternoon. I have no disclosures. Okay, so the first thing I want to cover are the current trends in the incidence of rejection and immunosuppression regimens. And this data comes from, everybody goes back to the HLT registry because it's really the most comprehensive registry of transplant across the world. And what we see from this particular slide is that, there's been a decreased rate of hospitalization for rejection. So it seems that over the errors that we see shown here, that the incidence of rejection have decreased. That's cellular rejection primarily. If you look at the percentage of people who have treated for rejection, it's also decreased dramatically. And so I had a discussion with one of my colleagues yesterday about how often are we seeing rejection the first year after transplant. And it's becoming almost, it's rare. It's now down to about 12%. So something with our therapies have really changed, and we're able to bring down the number of people who have a treated rejection the first year after transplant. If we look at induction therapy, whether or not, because some programs use induction, others don't, and it sort of depends on what the patient has in terms of, do they have sensitization or do they have renal insufficiency as to whether or not we choose to use induction. But if you look at the percentage of rejection the first year after transplant, it's really no different between people who receive induction and those who do not. This is a survival curve. This actually goes back to what Dr. Eisen just discussed in terms of survival after transplant based on PRAs, pre-transplant. And you see there's really no difference or significant difference except in the groups that had 0 versus the 10 to 39%. So that's all good news for transplant. When you look at what immunosuppression is used for maintenance, primarily now, as Dr. Kim showed you earlier, the regimens are consistent of tacrolimus, CellCept, and prednisone. And across a lot of the programs in the US, the percent of people who are still on prednisone at the first year is dramatically down. So it's interesting to see across the world that it's still at 80% at 1 year. The next thing I want to show is what the incidence of rejection is based on immunosuppression regimens. And as you've seen earlier, tacrolimus MMF group have fewer rejections the first year. So that's why by far and away, that's the most popular combination that people use as a maintenance regimen. This shows the hospitalization rate for people after transplant. So the first year, 2 to 3 years, and also 4 to 5 years. And the good news for patients who go on to be transplanted, if you see here in the red, the vast majority of these patients are never hospitalized in any of these particular time periods. What I want to point to you is the hospitalization rate for rejection. And that's highest the first year after transplant and steadily decreases over the life of the transplant. So this really is a testimony to the current regimens that we use, and it seems like at least for cellular rejection, we're doing quite well. So in terms of treating cellular rejection, that depends on the biopsy grade, the timing post-transplant, and whether or not you have graft dysfunction. So if this occurs early after transplant, you're very aggressive. If patients have associated graft dysfunction, you're also very aggressive. So in terms of how we classify cellular rejection, grade 0R is no rejection. Grade 1R, you have some interstitial edema, infiltrate, and up to 1 area of myocyte damage. Moderate rejection, or 2R, you have 2 or more foci of infiltrate with some associated myocardial damage, but when you get to 3R, which is severe, you have diffuse infiltrate along with edema, hemorrhage, and vasculitis. So once your pathology comes back and you want to make a decision about what to treat, for 0, there's no treatment. For 1R patients, if they have no evidence of graft dysfunction, you don't treat. If they do have evidence of graft dysfunction, then you would treat. When you go to 2R rejection, which is considered moderate, their treatment depends on whether or not the patient is early after transplant or later after transplant. So within the first 3 months after transplant, you're going to be aggressive and treat these patients with an IV steroid pulse. For patients who are greater than 3 months after transplant, you can treat this at home with their oral steroid pulse. And with both of these cases, about a week after their treatment, you have them come back to rebiopsy. Now for patients with graft dysfunction, regardless of what the biopsy score is, or for people who in their biopsy score have evidence of severe rejection, then you're going to have to be very aggressive about your treatment. And so that includes admission to the ICU for a IV steroid pulse as well as cytolytic therapy, which the popular agent for us is thymoglobulin. With this, you're going to also biopsy the patient and keep them in the hospital until you see the biopsy grades start to clear. If this doesn't work, then you go to what we call DEFCON 3, which is a regimen that Dr. Eisen just talked to you about. That's pheresis, IVIG, and rituximab. So what I really want to spend the most time on, we've been talking about this morning, is this theme of antibody-mediated rejection. And first I want to talk about the pathophysiology. So if you remember, the antibody-mediated rejection is, as Dr. Eisen just talked about, recipient antibody against donor HLA antigens on the endothelial cells. So this leads to tissue injury by complement activation and also immunoglobulin deposition. So how does that manifest itself on biopsy? So on biopsy, you're going to see endothelial edema, evidence of complement fixation, and also intravascular macrophages. So that's what you see on histology. There's also immunopathologic and serologic testing that go along with diagnosing AMR. And so with these criteria, AMR has gone from, when I first started training in transplant, something called biopsy with a negative, rejection with a negative biopsy, which means that you saw no evidence of cellular rejection, but you had graft dysfunction, to now using a sophisticated staging system, which I'll go over in the next couple slides. So this is actually just a pictograph of what AMR looks like. So unlike cellular rejection, where you have lymphocyte infiltrates, with AMR you see endothelial swelling around the capillaries. And in the past, this was actually called vascular rejection at one point. In terms of figuring out whether or not there's complement deposition, what you see here are C4D staining, so it's around the capillaries, and C3D staining. So if you have C4D staining, that's by itself evidence of AMR, but if you have a combination of positive C4D, and C3D staining, then you're pretty guaranteed that you're actually working with antibody-mediated rejection. Now, treatment. This is where things get tricky. So there are a couple of things when you're trying to decide about treating AMR that you have to consider. First is whether or not you have graft dysfunction. So that you generally always treat, you do treat, even though you may be wrong. We'll get into that a little bit later. The other thing you're looking for is on histology, evidence of endothelial swelling around the capillaries, as well as evidence of complement deposition. So that's the main thing you're looking for in histology. But sometimes what you'll find out is that when you do C4D staining and C3D staining, they're actually negative. So in that situation, you wonder, what should I do? There's also situations where you have patients who the histology is bland, but yet the C4D and C3D are positive. So the question is, what do you do with that? There are also cases where you have nothing on biopsy, even though you have severe graft dysfunction. So those are the cases I'm going to try to go through as we go through the remainder of this talk. But for purposes of diagnostic criteria, AMR 0, there's nothing on the biopsy. AMR 1, the histology is positive, but yet your C4D and C3D are negative. And then you can go along from here up to the worst case scenario, which is where you have positive across the board. So diffuse infiltrates and also positive staining. So I'm going to talk about the burden of AMR, and that's actually very difficult to define because the problem is the definition has changed over the decades. So depending on who you read and what era you read, it could be anywhere from 20% to 40%. So the true incidence is not well established because our definition has changed. The presence of antibodies pre-transplant, or sensitization, as we just heard, increases the risk of acute graft loss. And so desensitization is required to decrease waiting time for a compatible organ. When there are antibodies that are formed post-transplant, or de novo antibodies, that's associated with acute rejection if they're antibodies against HLA class 1, and chronic rejection if they're against HLA class 2. And chronic rejection is AMR, and also has an increased risk of developing coronary allograft vasculopathy. The other thing that you have to think about when you're treating AMR is the presence of donor-specific antibodies, which their presence is associated with increased mortality. So this is just a scheme of what we've been talking about this afternoon. And as you heard from our discussion on primary graft dysfunction, there's a lot of injury that occurs before the transplant. It has to do with ischemia reperfusion, drugs that are used at the time of harvest, as well as various drugs that are used. And then, of course, the big elephant in the room is what the immune status is like of both the donor in terms of preformed antibodies against the recipient. If things go well, you have a accommodation, which allows you to decrease immunosuppression across the life of the graft, and patients have long-term graft survival. If things don't go so well in terms of your matching, you may have AMR, the development of coronary artery vasculopathy, as well as chronic rejection. And I can't say one-to-one that AMR leads to CAV, but there's an association. And I can't say that AMR in itself leads to chronic graft rejection. Those things are, or chronic rejection, those things are being worked out as we speak because, as I said earlier, the definition has changed. But all of these things lead to eventual graft loss. And in terms of graft loss, I'm going to point you to this green line here. This is also from the ISHLT. So as far as the ISHLT is concerned, graft failure means that the ejection fraction is decreased and the patient is either retransplanted or died. But if you look across the span, the cause of it here at greater than 15 years is different than at the first 30 days. So the first 30 days is primary and secondary graft loss either due to a surgical problem, whether or not the patient has primary graft dysfunction, whether or not the patient has hyperacute rejection. That's different than what we see over here, which is the situation where we have chronic rejection, which is most likely due to AMR. And I continue to say most likely due to because we've all seen these cases where patients have a completely clean biopsy and yet the heart isn't functioning, and also with normal coronaries. So just to go over how antibody-mediated rejection and SCORE correlate with cardiovascular mortality. And this is from Hammond et al., pathologists at University of Utah, and they went back and looked at their biopsy samples from 1985 to 2010. They had over 31,000 samples to evaluate, and they were able to correlate that with clinical outcomes in these patients. And what she showed is that for patients who had no evidence of AMR in any of their biopsies, that the survival was greater than those who had evidence of AMR3 or severe AMR versus those who had AMR1 and AMR2. So the current definition that we have does discriminate between survival for patients in terms of AMR. So it is important to treat AMR. The question just becomes, what cases do we treat? This also shows that the survival rates for people who never had rejection or people that had cellular rejection were pretty similar, and people who had any form of AMR were actually less than those patients. So AMR, again, is very important to diagnose appropriately and to treat. So the next question everyone should be asking me is, well, how in the world should you monitor for AMR? Especially now that we're doing fewer protocol biopsies. Do you only monitor for AMR if the patient has graft dysfunction? If the patient has heart failure symptoms, what's the best way to do surveillance for looking for AMR? So the ISHLT came up with a consistent statement on this, and they say that you should monitor for AMR with every protocol biopsy. That makes sense. And they also say you should look for circulating antibodies very frequently during the first year after transplant. So at the first, so 2 weeks later, then at 1, 3, 6, and 12 months, and then after that, if clinically suspected. So every program has to sort of come up with their own way that they want to look for or monitor for AMR. So this is a very complicated slide because from this particular consensus statement, they interviewed a number of programs and found out that everybody does something different in terms of how they monitor and which AMR cases they treat. What everybody's decided on is if the histology shows severe AMR, that you're going to treat, regardless of whether or not the patient has graft dysfunction or not, regardless if they have DSA antibodies or not. So AMR3 on histology is going to require treatment, and those treatment options are exactly what Dr. Eisen just talked about in terms of desensitization, same sort of treatment. So very toxic stuff. When you get into patients who have no evidence of AMR on their biopsy, but they do have graft dysfunction, then the question is, well, what do you do with these people? So these are the patients who come in with heart failure and you biopsy them and they're still biopsy negative. There's nothing there. There's no cellular, there's no evidence of AMR. So the question is, what do you do in this group of patients? And this is where things differ, and it's sort of at the program's discretion. If DSA is positive, you're going to go ahead and treat. And they're actually suggesting that if the DSA is negative, that you can just monitor. The management is unknown. It's sort of dealer's choice. So that's sort of a difficult case which we've seen where people have graft dysfunction, no evidence of AMR cellular. How do you follow these people? In terms of AMR 1 and AMR 2, so that's mild and moderate. If they have graft dysfunction and DSAs, you definitely treat. If they don't have DSAs, it's sort of dealer's choice as to which way you go. They're saying management unknown. I can tell you in our case, we would definitely just treat because we see histologic evidence of AMR and we have graft dysfunction. And as I went over earlier, for people who have AMR 3 on histology, there is agreement on treatment for all of those groups. But this is a nice consensus document that everybody should look at in terms of what they're deciding in terms of treating for AMR or when to treat. These treatment options I won't go through because you just heard from these from Dr. Eisen, but it's basically pheresis, rituximab, and IVIG. One of the things that was touched on earlier is that the side effects from this and the morbidity associated with taking these treatments is pretty high. So that's why a lot of people, for those who have mild AMR but no graft dysfunction, decide they should just follow the patients over time before they decide to treat or not. So in terms of a conclusion for treatment, current immunosuppression regimens have decreased the incidence of treated rejection. That's great news. We now are focusing on, as a field, on AMR, which we know adversely affects graft survival, and in the early phases can result in acute graft loss, which is hyperacute rejection, hopefully with adequate desensitization protocol shouldn't happen. And then over the long term leads to chronic graft dysfunction and transplant vasculopathy. In terms of treatment strategies for asymptomatic AMR and surveillance, there's no uniform approach really, so I always just ask people to take a look at what your program outcomes are and what you see here in the consensus document. Okay,